provides information about the health of the eye and possibly the health of the patient as a whole. At the end of this activity, you will be able to demonstrate the ability to obtain and document an accurate pupillary examination on a patient with an acute eye complaint. You will also be able to describe the significance of the following abnormal pupillary findings. Pathological anisocoria, anisocoria meaning unequal pupil size, a relative afferent pupillary defect, a unilateral fixed and dilated pupil, pinpoint pupils, and a teardrop-shaped pupil. Inspect the pupils for size, shape, and symmetry looking for anisocoria. Then observe the direct response, which is constriction of the illuminated pupil. Then observe the consensual response, which is constriction of the opposite pupil. The swinging flashlight test is then performed looking for a relative afferent pupillary defect. This video demonstrates accommodation, which is pupillary constriction with convergence of the eyes.
Okay, so just keep your eyes on my finger, just follow it in. That's fine. Now if you can just look at the wall behind, and just look at my finger again. Wall behind, and my finger again. That's great.
Documentation of the pupillary examination includes the pupil size, typically in millimeters, and compared to the other pupil. Shape, which is normally round but can be teardrop shaped or described as peaked. Speed of reactivity to a light stimulus may be described as brisk, sluggish, or non-reactive. The reactivity can be described as a direct or consensual response. The presence of a relative afferent pupillary defect should be documented. The response to accommodation should also be documented, but it is often left out. A normal examination example is: pupils are 4 millimeters in dim light, round and briskly responsive to direct and consensual light and accommodation. An abbreviated version might be PE422RRLA, which stands for pupils are equal 4 millimeters in dim light and constrict to 2 millimeters, round and reactive to light and accommodation. An abnormal examination example might be pupils are equal 4 millimeters in dim light with a right relative afferent pupillary defect. Causes of pathological anisocoria include acute closure glaucoma, cranial nerve 3 palsy, pharmacologic anisocoria, Horner's syndrome, and traumatic iritis. This video demonstrates a right relative afferent pupillary defect. Note the right pupil dilates when illuminated during the swinging flashlight test. Causes for a relative afferent pupillary defect typically are evil and include optic neuritis, glaucoma, optic nerve trauma, retinal detachment, or vitreous hemorrhage. A unilateral fixed and dilated pupil is most frequently caused by evil conditions. The differential diagnosis includes uncal herniation, acute angle closure glaucoma, posterior communicating artery aneurysm compressing the oculomotor nerve, an iris tear, traumatic mydriasis, post-ictal state, AIDS tonic pupil, and pharmacological mydriasis. The causes of pinpoint pupils include opioid overdose, pontine hemorrhage, cholinergic toxicity, medications such as clonidine, pilocarpine, uveitis, old age, also called senile meiosis, and bright lights. A teardrop-shaped pupil, especially if acute, suggests evil. Causes include open globe, iris tear, iridodialysis, which is where the iris is torn from its root, post-surgical iritis with posterior synechia, and congenital causes, which are not evil.